This is the medical management of patients with heart failure with reduced ejection fraction. All patients with New York Heart Association classes 1 to 4, that's all of the classes, with left ventricular ejection fraction of 40 or less, should be on an angiotensin-neprilysin inhibitor. This slows the disease progression and improves the mortality. These patients should also be on beta blockers like metoprolol, succinate, carvedilol, and bisoprolol. This also reduces hospitalizations and also reduces mortality. All patients with New York Heart Association classes of 2 to 4 with volume overload should be given diuretics, typically a loop diuretic with metolazone. This improves symptoms and reduces hospitalization, but does not improve mortality. New York Heart Association classes 2 to 4 with left ventricular ejection fraction of 35 or less should also get an aldosterone antagonist. This reduces symptoms and also improves mortality. If you're class 2 to 4, you should also be on an SGLT2 inhibitor. This is originally a diabetes medication that makes you pee out more of the glucose in your blood. It's been shown to help in heart failure by improving mortality and reducing symptoms. Lastly, if you can't tolerate the angiotensin system blockers, like ACE inhibitors or like these neprilysin inhibitors or aldosterone antagonists, then you should be on Isosorbide, dinitrate, and hydralazine. These may improve mortality. The studies are kind of mixed on this, but they do improve symptoms. Lastly, if you have persistent symptoms despite all this other therapy, you can throw on Digoxin. This reduces hospitalization, but does not improve mortality.